When the immune system fails to recognize infectious agents, severe local and system infections are not suppressed or controlled. Immune system failure can be the result of a primary, also referred to as congenital immune deficiency, in which one or more parts of the system are not functioning properly from birth. Immune system failure can also be secondary, also referred to as acquired after birth, as the result of a viral infection, contact with a toxin, or medical therapy. These problems can cause a normal immune system to stop functioning or to function less efficiently. The consequences for the immune deficient patient can range from mild, localized health problems to total immune system failure. After this lesson, you will be able to use appropriate techniques to reduce the risk for infection in an immunosuppressed patient. Use standard precautions to prevent human immune deficiency virus transmission to you, patients, and other health members. Ensure that confidentiality of HIV status is maintained by all healthcare team members. Teach all sexually active people to use safer sex practices. Use non-judgmental approach when discussing sexual practices, sexual behaviors, and recreational drug use. And respect patients' rights to inform or not inform family members about his or her HIV status. Now we're going to discuss some immune deficiency and facts. It could be primary or congenital. Generally, the immune system doesn't function properly from birth, and it's usually in the result of genetic mutations. Secondary immune deficiencies are acquired after birth. An example is AIDS, acquired immune deficiency syndrome. AIDS is caused by the HIV virus, the human immune deficiency virus. Other examples are iatrogenic. The virus has killed over 30 million people since being reported in 1981. 1.1 to 1.8 million people currently live in the United States with HIV. Generally characterized by immunologic deficits, opportunistic infections, secondary infections, and malignant neoplasms. Once a person is infected with HIV infection, CD4 plus T cells, or also called helper T cells, are disabled and killed. CD4 plus T cells are crucial in the immune response and signaling cells in the immune system. Well, let's discuss the pathophysiology. The virus has an outer envelope with docking proteins called GP41 and GP120. Inside the virus is genetic material along with enzymes, reverse transcriptase and integrase and protease. The virus must first get into the host's blood. Once there, it hijacks the cells, especially the CD4 plus T cell, because of its special receptors. Once inside the human cell, the virus must get its genetic material into the host cell DNA. Reverse transcriptase takes HIV's ssRNA and converts it into dsDNA, which makes the virus genetic material the same as human DNA. Integrase allows the viral dsDNA to be inserted into the host dsDNA. The host then replicates the virus in long strands. Protease is a chemical scissor which cuts the virus into usable particles. It then moves to the cell membrane and buds of looking for another CD4 plus T cell to continue doing its work. The virus has given the CD4 plus T cell new genetic instruction. It is now an HIV factory. HIV overwhelms the immune system. CD4 plus T cells numbers drop and the viral load increases. Okay, so let's discuss some clinical manifestations. The patient can experience fever, night sweats, chills, headache, and muscle aches. Note, these are usually the first clinical manifestations noted. They will also have lymphocytopenia. They'll have an increased production of incomplete and non-functional antibodies. They'll have abnormally functioning macrophages, and then there is a development of opportunistic infections. Diagnoses lead to an HIV positive test, CD4 plus T cell count is less than 200, or they develop an opportunistic infection. Once the patient has the diagnosis, it always stays, even if they return to normal cell counts. Opportunistic infections are those caused by organisms that are present as part of the normal environment and are kept in check by normal immune function. Everyone who has AIDS has HIV infection. However, not everyone who has HIV infection has AIDS. And the distinction rests with the number of CD4 plus T cells the patient has and whether any opportunistic infections have occurred. So let's discuss the CDC's defining conditions. In December of 1992, the Centers for Disease Control and Prevention published the most current list of AIDS-defining conditions. These conditions list opportunistic infections the patient will have or could experience. Wasting syndrome people who are not infected with HIV may also develop these diseases, but does not mean they have AIDS. Well, let's talk about incidence. The person with HIV infection can transmit the virus to others at all stages of the disease, but the recently infected person with a high viral load can be particularly infectious. There are some people that will be positive for the virus but never develop symptoms because of a Delta 32 mutation on their T cell receptors. This is just not a disease for people that are gay. Women are the fastest growing group with HIV infection. Over 72% of new cases are reported in racial and ethnic minority groups, especially the African Americans and Hispanics. Fatality rate is at least 60%. There remains no cure. It is now a chronic disease. Transmission is through most body fluids such as blood, semen, vaginal secretions, breast milk, amniotic fluid, urine, feces, saliva, tears, cerebral spinal fluid, lymph nodes, cervical cells, corneal tissue, and brain tissue. Transmission is usually by sexual contact, parenteral, or perinatal mode. The CDC's approach is to teach about abstinence, for spouses to be faithful, for the use of condoms, and any form of sexual expression may result in virus transfer. The vagina has more mucous membrane than the penis, so women are at a higher risk. You want to teach patients proper cleaning of needles and syringes. They want to rinse with clean water, then well with ordinary household bleach. They need to shake for 30 to 60 seconds, and then they also need to use the needle exchange programs. Also, all donated blood is screened for HIV antibody. However, because of the window period, some donated blood with HIV may be in the health system. There is a 25% risk for infants with HIV-positive mothers. That risk drops to 8% if the mother is on an appropriate drug therapy. Sharp injuries are the main means of occupation related to HIV infection for healthcare workers. You want to use standard precautions always and routinely. See Chart 21-3 for PEP. This is updated frequently by CDC, so always use the CDC as the gold standard. I am going to discuss a few key features of AIDS. Chart 21-6 on page 365 of your textbook will provide you with the complete list. First, we'll discuss a little bit about opportunistic infections. They do not pose a threat to the immunocompetent healthcare worker caring for a patient with HIV or AIDS. Use appropriate precautions to the specific disease. A few examples could be protozoal infections such as PCP and toxoplasmosis encephalitis. A few fungal infections such as Candida albicans, cryptococcosis, and histoplasmosis. Then there are some bacterial bacterial infections such as Mycobacterium avium complex and tuberculosis. Viral infections such as CMV, HSV, and VZV. There are chances for malignancies such as Kaposi sarcoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma, invasive cervical cancer. Other changes can affect the endocrine system, HIV dementia complex, AIDS wasting syndrome. There may be even some skin changes. These changes may be related to medications for the HIV treatment or infections. Some of the labs will include a lymphocyte count. They will be leukopenic. There will be a CD4 plus T cells. They will be low, maybe as low as 100. Normal is usually 500 to 1600. Antibody tests to measure the patient's response to the virus or antigen. And then a viral loading test to test presence of HIV viral genetic material in the patient's blood. Okay, so now we are going to discuss drug therapy. Some of the drugs have antiretroviral effects, meaning that they slow the viral replication, but they do not kill the virus. Monotherapy promotes drug resistance and does not improve the duration or quality of the life for the patient. It is preferred to have cocktails that are created of all highly active antiretroviral therapy, and it's important to take the meds on time. Even a few missed doses per month can promote drug resistance and allow increased viral load. Nucleoside analog reverse transcriptase inhibitors compete with the actual nucleotide for placement in the DNA. They suppress the production of reverse transcriptase and inhibit the viral DNA synthesis and replication. Some examples are Retrovir, Videx, Xaret, Imtriva, and Zygon. Non-nucleoside reverse transcriptase inhibitors inhibit the synthesis of a reverse transcriptase. They do not kill the virus. Examples are Receptor, Sustiva, and Etravirine. Protease inhibitors block the HIV protease enzyme, preventing viral replication and release of viral particles. Some examples are Norvir, Crixivan, Invarase, Varicept, Coletra, Rayacets, Lexiva, and Prezista. Fusion inhibitors block the fusion of HIV with the host cell by locking the ability of GP1 to fuse with the host cell, and it prevents infection of the new cell. Examples is Fusion. Entry inhibitors is a new group that blocks the CCR5 receptor on CD4 plus T cells. Example is Cellzentry. Integrase inhibitors, the newest type, block the enzyme integrase, which is needed to insert the viral DNA into the host cell's human DNA. This stops the viral replication. An example is Icentris. Okay, we're going to discuss a little bit about collaborative care for impaired gas exchange, pain, and nutrition. For impaired gas exchange, Bactrim is usually chosen first, but you want to watch for adverse reactions. If the CD4 plus T cell count is less than 200, or for those that already have a PCP, they want to use Pentum IV, IM, or aerosolized. Durovasine pneumonia is common in HIV patients. For pain, they may use NSAIDs, tricyclic antidepressants. They may also need to use anticonvulsants or opioids. For nutrition, they may offer meds such as Nizoral, Diflucan, and antifungals. They encourage a high-calorie, high-protein, and nutritionally sound diet. They may develop fat intolerance. Total parenteral nutrition may be needed. For mouth care, you want to teach them to rinse with sodium bicarbonate with normal saline every 2 hours. Use a soft toothbrush. Vicus lidocaine may be needed. You can see chart 21-10 on focused assessment items. Some acquired secondary immune deficiencies may be related to other conditions that cause the loss of immunoglobulins or destruction of lymphocytes. The most common cause of secondary immune deficiency is the use of drugs and other treatment modalities for various diseases. Okay, first we're going to discuss therapy-induced immune deficiency, non-AIDS. It can be caused from drugs such as cytotoxics, corticosteroids, and cyclosporine, and then treatments such as radiation-induced, and these are modalities for diseases. The challenge is to have maximum therapeutic effect without leaving the patient overly immunosuppressed and susceptible to serious complications. Okay, so first we're going to discuss the drug-induced immune deficiency. Cytotoxic drugs are used in treatment of cancer and autoimmune disorders, and they interfere with the rapidly dividing cells such as lymphocytes and phagocytes. Corticosteroids are hormones used to treat many autoimmune diseases, neoplasms, and endocrine disorders. They have both anti-inflammatory and immunosuppressive effects. They stabilize blood vessel membranes, which blocks movement of neutrophils and monocytes. It also prevents inflammatory chemical production. Corticosteroids also keep T cells in the bone marrow, and it decreases the IgG production and reduces antibody antigen binding. Side effects of steroids are CNS changes such as euphoria, insomnia, and psychosis. CVS such as edema and hypertension, GI such as irritation, ulcer, increased appetite, and then you have others as hyperglycemia, muscle weakness, delayed healing, bone density loss, and fat redistribution. And then there's cyclosporines such as Sandamune, Neural, and they block the helper T cell growth and development, and they're used to prevent organ transplant rejection and graft versus host disease. Let's talk about the radiation-induced immune deficiency. It's toxic to dividing and resting cells. Lymphopenia occurs, and it depends on the location and the dose of the radiation. Exposure to the ilium and femur in adults can cause immunosuppression because these bones are the primary blood cell producing sites. Regardless of the cause, infection prevention is the key. Good hand washing and aseptic technique for any invasive procedure. Okay, so now we'll talk about the primary or congenital immune deficiency. They're very rare. They're classified by the type of immune function that is impaired. There's Burton's gamma globulinemia, and you must replace the antibodies, and best results are to start early, then repeat every 3 to 4 weeks. The common variable immune deficiency, again, is the same treatment. Then you have selective immunoglobulin A deficiency. It is not treated with immunoglobulin. This concludes this lesson. If you have any questions related to the content of this lesson, contact the instructor.